right. Well, while people roll in, Rebecca, do you just want to kick off the topic at
Yeah.
hand today and what we're gonna spend the next few minutes on?
Yeah. So thank you guys for joining Yuvo Health today on this Q&A session with Dr. Lynda Hoang of Digestive Health Associates. We're really excited to partner with you guys this month on colon cancer awareness. So I will pass this off to Dr. Lynda Hoang to kind of kick off and give us some background information on her and the work that she's doing.
Well, good morning, good afternoon to wherever you are. My name is Lynda Hoang, and I'm a gastroenterologist at Digestive Health Associates in Reno, Nevada. I've been here for about 3 years, and just a quick background information about me. I've been a nomad for as long as I can remember with my medical training. Started undergrad at Baylor University in Houston, Texas. Waco, Texas. And then made my way to Northern California for medical school at Touro University. Did internal medicine residency at Parkview in Colorado, and then GI fellowship in Las Vegas. So things I do here at Digestive Health is I do general GI and some hepatology cases, and we do screening colonoscopies, both diagnostic and as well as things like therapeutic procedures. And so since the month of March is colon cancer awareness, I'd like to take this time to talk to you about some of the epidemiology, the modifiable and non-modifiable risk factors for colon cancer, screening modalities, and some of the challenges regarding spreading the awareness of colon cancer. So just a quick background. Colon cancer is the third most commonly diagnosed cancer globally in male patients and second in female patients. So a lifetime incident would be 1 in 25 of patients will have some type of diagnosis of colon cancer. And each year, about 155,000 people get diagnosed with colon cancer. So out of all these cancers we have, colon cancer is one of the few cancers that are preventable, meaning we can screen early and avoid that. And so some of the things that we talk about with our patients here, our practice is how to prevent colon cancer. And the goal is to screen early, identify polyps, and remove them as early as 45 for patients with average risk factors. Now, for patients who have a family history of colon cancer less than the age of 60, then we start screening either at age 40 or 10 years younger than the age that the relative was diagnosed. And just a reminder, first degree relatives include a parent, a sibling, or a child. And so also we talked about risk factors of colon cancer. So some of the things that non-modifiable risk factors are genetic, hereditary colon cancer syndrome that cannot be changed. So patients with Lynch syndrome or FAP, patients with inflammatory bowel disease such as Crohn's disease and ulcerative colitis, or patients who have a personal history of colon cancer or a family history of colon cancer. Now, modifiable risk factors for colon cancer are diet and lifestyle. So obesity has been known to increase the risk. Sedentary lifestyle, also processed meats and food, and also red meat are things that they can change. And then also for patients who are smokers and people who drink alcohol, those are also modified risk factors. And so some of the barriers that we do encounter here in our office are just the idea of getting a colonoscopy, which is a procedure. So patients wonder what is the process that entails during a colonoscopy. So during our consultation appointment, we talk to them about what they expect on the day of the procedure, their purging process or getting a bowel preparation the day before their procedure, and also whether sedation is given, or some patients you like not to get sedation because of various reasons. But we also emphasize that yes, the patient will be comfortable during their procedure. And I think the main thing is patients don't know what to expect, and the unknown is what causes a lot of anxiety for patients. Some patients, the thought of having a foreign object going through the rectum is, worrisome for them. And so that's the process of the consultation, which is to educate these patients on those things. Another thing is after the procedure, a lot of patients will say, that's it, we're done. So really the worst part is the cleansing part, which takes, the day before we ask them to be on a liquid diet. We start the cleansing part during later on in the day. And then on the day of the procedure, they're very comfortable, they're sedated, and it's about a 20-minute procedure and they're done. And if everything is good and they're average risk, then the 10-year recall.
Awesome. And some additional questions. So, what do you think are some good talking points that a primary care provider can give their patients, that they're interested in getting in a colonoscopy, since it is kind of held to your office as a gold standard?
Yeah, so some of the topics is first just to make them aware that colon cancer is preventable. And some patients have the idea that, well, if I have colon cancer, I would have symptoms like, for example, abdominal pain, GI bleed, or anemia. But sometimes I've seen a couple of cases where patients are asymptomatic when we found it incidentally on screening. So that's one thing we do want to emphasize. Also, educate patients on the age of screening. Some patients are still thinking their screening age is at 50, which is now 45 years of age. And third is to reassure them that this is a prevention process, meaning we detect it early, remove the polyps, then they don't have to worry about it. And I also believe that, educating patients on things that can prevent colon cancer, which includes, colon cancer screening, the different types of screening that are available. So the stool test, for example, versus the actual procedure itself will, give patients the options based on their preferences, their medical history, their comorbidities. So then it's a team decision making and not just the physician telling the patient what they should do.
Okay, great. Thank you. So, what types of colon cancer screening tests do you turn to most often, and why? Or what are different options that are available?
So there's various options. There's a stool test, which is the FIT or fecal immunochemistry test. There's the Cologuard. There's the virtual colonoscopy, which is a CT colonography. And also the gold standard that we use is the colonoscopy procedure itself. Now, keep in mind the stool test is to detect if there's any abnormality, whether it's positive or negative. But if it's positive, patient will need a colonoscopy. So what I recommend is if the patient is appropriate age, they don't have any significant risk factors, get a colonoscopy done. So if we see a polyp, we can remove it right then and there. Another thing is, some of the stool tests, it can have a miss rate, depending on what data you're looking at, between 15 to 20%. So some patients may have polyp and it doesn't show up as positive on the test. And that is something that can be prevented with just a colonoscopy.
And what about the differences with like using like a Cologuard per se?
Yeah, so with the FIT test, it's just a quick, smear, and that's an annual study versus a Cologuard where they have to, collect their entire stool sample, and it's every 3 years. So Cologuards are fine in that sense, but the thing is, like I said, you can't, even if there's small polyps, there is a small percentage of miss rate. And so colonoscopy is gold standard in the sense that you go and you see it and you take it out. So they don't have to do two separate types of screening per se.
Okay, great. And I know you said, there's some pieces, as far as colon cancer, it is preventable. Are there any other things that you wish patients knew about colon cancer?
Yeah, and as I previously mentioned, patients think that if they have colon cancer, they should have symptoms, weight loss, anemia, GI bleed, pain, for example. But there are silent colon cancers where patients are asymptomatic. They don't have any symptoms. And so, or maybe they have symptoms that do not seem like colon cancer related. So I actually have one patient that I always remember. She's a very young lady in her 40s, came to me for constipation. That was her main concern. And so usually, someone who's healthy like that with constipation, we usually give them different options to help them have regular bowel movements. But I decided, given her family history, which is nothing significant, it's mostly secondary relatives, I thought let's just do a colonoscopy just to be sure. And we did find rectal cancer. And so she had surgery after that. So it's something that we have to let the patient know that, you know, you may not have typical symptoms or may not have any symptom, but it's best to do a colonoscopy just to make sure.
And can you elaborate a little bit more on like maybe like different rates of survival based on the time frame for detection?
Yeah, exactly. So if it's detected early, the percentage is about 90% survival, which is very high. Um, and as we get older, and we don't get screened, then the risk gets higher. And so that's why early detection is important, starting at the age of 45 versus, starting at 60, for example. And for someone, even if they're in their 70s, they've never had a colonoscopy, we still say at least get a one-time screening just to make sure we rule out cancerous lesions and remove polyps.
So something that we tend to see, especially in quality, is that we let patients know that they're due for certain screenings. They should be coming in for a screening. And maybe they come in and see a GI specialist, and then after that, they don't do a follow-up. Is there any best practices around like getting those patients to come in and kind of close that care gap and make sure they're getting the quality care that they need?
Yeah, I think the most important thing is education and communication, letting the patient know and being honest about it, what to expect for their procedure. And I think that by just seeing a GI doctor, they have direct questions that maybe primary care it is something that they don't do. They can just send to us and we can answer those questions for them. Reassurance, education, and also just during my consultation, sometimes I will bring models of colons so they can see what I'm doing during the procedure and show them pictures of what a colonoscopy and a colonoscope looks like. So that way they feel more comfortable. And once you have that rapport with the patient, it also makes the whole process easier for them.
What has been your experience working with different types of patient population groups? Also looking at different like race ethnicities or even ones that have other chronic diseases and making sure that they're staying on top of their care and also getting their colon screening.
Yeah, data has shown that African American patients and Native Americans have a higher risk for colon cancer. Um, and also male patients versus female patients. And in my practice, I have more female patients just because I'm a female gastroenterologist. So a lot of patients come to me for that. And then also patients who have renal transplant, who are on immunosuppressive therapy, have a higher risk of colon cancer. So those type of patients should definitely be screened at an age-appropriate recommendation per guidelines. And so I think by having those patients come in early to see us, we can start the process, educate them, and depending on the comorbidities, we can talk about different type of screening modality.
Okay, great. I wanted to once again just remind, if you do have any questions, feel free to drop them in the chat, or we can definitely kind of touch on those. Yeah. So what do you think are the most, like the top 3 things that patients should know or providers during this month of colon cancer awareness and things that we can take out of this?
Top 3 would be the age of screening is at age 45 for average risk patients. Of course, the screening age changes depending on family history and their personal history of colon cancer. Number 2 is that a colonoscopy is a comfortable procedure. You are sedated, you are comfortable. The worst part, I would say, is the cleansing process, where a lot of people don't like that. And the third is that the earlier you get a colonoscopy, the texture rate and the risk of getting colon cancer it is definitely reduced, meaning 90%, like I said, survival rate for patients to get detected early.
Great. I don't know if you have any other questions, Adrian.
Um, I guess do you have any advice to providers who might be um still struggling to close those care gaps in what they should consider? Um,
I think consider the patient's comfort level and also their perspective, because I know some patients do not want to have any foreign objects in that, very private area. And so I think by having that discussion with the patient, um, asking what their preferences are and seeing what's best for them. If a patient doesn't have any risk factors or family history, a fecal test I think is appropriate. But if they're high risk, then consider getting a colonoscopy over a fecal test. And communication is the most important thing, in my opinion. Being direct and honest with the patient, tell them what the expectations are during the procedure will also ease that comfort. And just having that patient-physician relationship makes a difference too.
and when do you or how do you bring up those conversations? Is it in regular visits? Is it through other modalities like email or text? Like what do you see?
Yeah, so for me, it's always direct conversation in person with the patient. They see me, I educate them what colon cancer is and the screening prevention and the guidelines. Then afterwards, if they feel, I kind of get a feel for how they are. If they're hesitant, for example, or their body language, would ask them what are their concerns, and if they express certain things, and we'll address it during that visit. So that way they feel more comfortable. And also bringing models in to show them during the consultation helps them too, so they understand what we do, what is a colonoscopy, where do we start and where do we end the procedure, and just going over everything with them from the bowel preparation, to the diet, and on the day of check-in to our surgery center.
And so you mentioned there's some things that you can do to reduce the, the risk factor for colon cancer, such as like smoking, alcohol, foods. Are
Yeah.
there like specific food groups or specific foods to avoid that maybe you can touch on?
Yeah, things as processed food has been shown because of carcinogens, increasing the risk of colon cancer, red meat, for example. So more of a healthy, lean protein, high fiber diet is healthier. Obesity is also another thing. So weight management is very important because of the comorbidities that leads to colon cancer, including heart disease, hypertension, hyperlipidemia, and lastly, avoiding recreational drugs or tobacco use, those type of things also help reduce colon cancer too.
Great. I don't know.
Are there any questions that people want to drop into the chat for Dr. Hoang?
All right.
Well,
Well,
I
I
guess
think
my
we go ahead.
I guess my last question, Dr. Hoang, is there anything we didn't ask you that you think that is important for providers to know?
No, I think you asked all the questions, and I think we addressed all of them on today's Q&A session. So thank you.
Okay, good.
No, thank you so much for your time and for your expertise. This is very helpful as our FQHCs go forth and, reduce colon cancer as best they can with early detection and getting patients in to get screened.
All right. Thank you for your attendance and for your time.
Thanks.
Thank
Bye.
you.